Well, welcome everybody, and thank you for joining us today. It's such a joy for me to introduce today's speaker, Professor Wafaa el-Sadr, who is the Dr. Matilda Krim-Amfar Chair of Global Health and also Professor of Epidemiology at the Mailman School of Public Health at Columbia, as well the founder and global director of ICAP. Through its work, we'll hear a lot today about the impacts of trying to do important work in some of the most resource-constrained parts of the world, for example, in sub-Saharan Africa and Asia. Dr. el-Sadr, you'll be interested to know many of our trainees hail from across the globe, and I always like to account for the particular experiences of our speakers. So in your case, Dr. el-Sadr was born and raised in Egypt and received her MD from the Cairo University Faculty of Medicine. She completed an initial residency in medicine at Cairo University Hospitals, followed by a second internship and residency at the Cambridge Medical Center here in New York City. She did her ID fellowship in New York University and a research fellowship at Case Western Reserve, and completed her training with the MPH from the Mailman School of Public Health, as well as an MPA from the JFK School of Government at Harvard. Many in the audience, I think, will be aware of Dr. el-Sadr's remarkable work over now several decades, impacting, as I say, the lives of, most importantly, I think for me, women and children living in resource-constrained parts of the world. She's focused most of her efforts on HIV and its impacts, and has really brought her sensibility as a scientist in bringing systems and data and the rigor of data analysis, for example, in the treatment of HIV and the long-term outcomes of patients living with HIV in those many countries. But she's also done important work, for example, in TB and multi-drug resistant TB, in Ebola and SARS, and even in COVID-19 most recently. Dr. el-Sadr has been recognized for her efforts in many, many ways. And just to mention a few of these many, she was given the Michael Pupin Medal for services to the nation by Columbia University, as well as the Stephen Smith Award for distinguished contributions in public health from the New York Academy. She was named to the Institute of Medicine here in the United States, and as well as a fellow of the African Academy of Sciences. Dr. el-Sadr, for me, is one of the most remarkable people working in public health. And I say it's really just such an honor and joy, Dr. el-Sadr, to have you with us today. And thank you so much.
And thank you very much for your very generous and kind introduction. I'm really very happy to be here with you today and to be with this group. And I can see on the screen already the names of people that I've known and worked with for many, many years in the field of infectious disease and public health. So it really is wonderful to be with you this morning. So let me start and share my screen. I hope you can see my screen. Maybe David, you can nod or, okay, great, thank you. You never know. So what I thought today is I'll really touch on two pandemics, two epidemics that are ongoing, both the HIV and the COVID-19 pandemic, and how they converge and what lessons we can learn in confronting one to help us address the other one. And I always tell people that we are living in a unique moment in history where all of us on this call and the global community are experiencing these two pandemics that are coexisting. So here's an outline of my presentation. I'm going to just give a very brief update on the status of both of these pandemics very briefly, then talk about the risk for COVID-19 amongst people living with HIV and outcomes of COVID-19 amongst people living with HIV. Then I'm going to dive a little bit deeper into the effects of COVID-19 pandemic on HIV-related services, mainly focusing globally and based on our own work in sub-Saharan Africa. Then take a touch on the lessons we've learned from HIV and the response to HIV, and end with a few conclusions. So let's talk first about the status of the global COVID-19 pandemic. As you're well aware, of course, the pandemic continues to grow. As of May 19th, which is yesterday, there were more than 164 million reported confirmed cases of COVID-19. This is widely acknowledged to be an underestimate because of the limitations in terms of availability of testing, and that most cases actually never get diagnosed, with more than 3.4 million reported deaths. And this is also thought to be an underestimate because, again, ascertainment of death and causes of death always is limited in many parts of the world. However, what's interesting is when we look at the cumulative reported numbers of cases of COVID-19, what's interesting in this pandemic is that most of the cases thus far have been reported from the Americas, from North and South America, as well as from the European region. And you can see the contribution in terms of the proportion of cases thus far reported from other parts of the world. But as you can see in this map here is that, and the red dots represent cases of COVID-19, is this pandemic has touched every part of the globe, which is rather remarkable. This is just rather remarkable to even contemplate this. And the top 5 reporting countries in terms of the cumulative numbers of cases continue to be led by the US, followed by India, Brazil, France, and Turkey at this point in time. Now, when we look at the share of the population that has had a case of, that has been diagnosed and reported with COVID-19, you'll see the darkest red, like the United States and Brazil as 2 examples, and several countries in Western Europe. This indicates that 1 in 20 of the population has been reported, has been reported as a case of COVID-19. So this shows again the magnitude and the impact on at a population level of this pandemic. And you can see, of course, other countries around the world and the impact of COVID-19 on these populations. And if we've been particularly interested, of course, in low and middle income countries, you can see that while overall Africa has been largely spared, there have been severe epidemics and surges that have occurred, particularly in Southern Africa. And of course, we know now that India is experiencing a horrific surge in the numbers of cases with loss of life. What about most recently? And this is another way of looking at the data. And this is the average daily cases per 100,000 population. So this is adjusted for population over the past week. And you'll see here that South America, in particular, several countries in South America continue to be very severely impacted with the infection with COVID-19, as well as, of course, you can see here the effect in India in particular. Now, in terms of the United States, as you're well aware, the US has experienced 3, what I call here in this curve, like 3 surges. You can see the first surge was last March and April, where actually this affected mainly, was manifested mainly in the Northeast, including New York City, New York State. And then a second surge that occurred last summer. And then the third surge that we experienced in over the holiday season recently. And thankfully, we're now, you can see here the recent drop in numbers of daily newly reported cases of COVID-19. We continue to experience in the US about 30,000 new cases per day at present. So it still remains a large numbers. We're nowhere near being beyond the pandemic. So we still have 30,000 new cases reported per day. New York City, in contradistinction, and of course in the US, we just reached a new milestone of more than 33 million reported cases of COVID-19. In New York City has been severely, of course, impacted, as you all were aware, with 2 surges that have been experienced, the last one over the winter holidays. And again, in New York City, thankfully, we are experiencing now a substantial drop in numbers of cases with about 700 or so new cases per day. So let me touch on COVID-19 vaccines, because I think we can't talk about the status of the pandemic without touching on vaccines. And I think also this is an important, as we contrast HIV and COVID-19, we're very fortunate to have already several highly effective and safe vaccines for COVID-19, while we are still seeking to find a single effective and safe vaccine for HIV. And the good news is that there's been a very robust pipeline for COVID-19 vaccine development. And as you can see, now 49 vaccines candidates that are in phase 1, the early research studies. But even in phase 3, which are these large studies that often include 30 to 40,000 participants, that are designed to evaluate efficacy and safety, there are several vaccine candidates already in the pipeline, and we have several vaccines that have been authorized or approved. So we're very fortunate to be in this situation. And of course, in the US, I'm not going to go through the details. We have 3 vaccines that are currently authorized for use by the Food and Drug Administration here, and that are recommended for use by the CDC. 2, the Pfizer, BioNTech, and Moderna use the mRNA technology, a new technology, while the Johnson & Johnson Janssen vaccine uses a benign adenovirus vector. All of these, the 3 vaccines are actually have high efficacy with more than 90% for the Pfizer, BioNTech, and Moderna vaccines, and overall 66% efficacy for J&J, but 72% efficacy as noted in the US component of the study that was conducted. I always need to caution people not to compare efficacy across these vaccines, because these studies, the studies for these 2 vaccines were conducted at an earlier time point than the study for the Johnson & Johnson Janssen vaccine. And therefore, they were in a different context with different circulating variants and so on. So it may not be intrinsic differences in the vaccine itself and its efficacy, but rather that the context of the pandemic and the variants that are circulating could have differed substantially. And we don't have, as of yet, any head-to-head comparisons of any of these vaccines. And the good news, as you know, is these vaccines have mild to moderate side effects, with the exception of a rare side effect that's been noted in about 7 out of 1 million vaccinations with the J&J Janssen vaccine that's been largely reported amongst women less than 50 years of age, that involves rare clotting disorder with severe thrombocytopenia. Also, on a global perspective, because our work is global, as you are well aware, there have been 2 vaccines that have been authorized for emergency use or pre-qualified for emergency use by the WHO. And these include the AstraZeneca vaccine, similarly using this adenovirus vector technology, and the Sinopharm, a vaccine produced in China that's an inactivated virus with an adjuvant. And both of these vaccines have been evaluated by the WHO and determined to be, again, given the pre-qualification for use. So that's good news. So these vaccines are the ones that are largely being used in the international context, particularly in low and middle income countries. So how are we doing? And this is where I start kind of touching on the similarities between HIV and COVID-19, is that we are, of course, experiencing some disparities in terms of access to vaccination, very similar to the disparities we noted certainly maybe a decade ago in terms of access to treatment for people living with HIV across the world. So here you can see in this map, and this shows the vaccinations per 100 persons, and the darkest green is the highest doses administered, the highest rates of vaccination. And you'll note that, for example, countries like the United States, as well as several Western European countries, Israel, the UAE, and Mongolia is another example, and some South American countries have achieved the highest coverage or uptake of vaccinations, while large parts of the world have had minimal uptake of vaccinations or access to vaccinations, including most of the countries of sub-Saharan Africa. So let me switch now and talk about the status of the other pandemic that we're experiencing. I think it's important to keep reminding everyone that HIV is, of course, not gone and remains an ongoing pandemic experienced both by people living around the world, including in the United States here, with parts of the US and geographic parts of the US, as well as certain demographic subsets of our population more severely impacted than others. But overall, for the latest data that are available for 2019, they're estimated to be 38 million people living with HIV around the world. And you can see here that, of course, again, as you are aware, I'm sure, the impact of this pandemic on sub-Saharan African countries that remain with the highest burden and the highest prevalence of HIV. In terms of the new numbers of infections, and this again should tell you that we continue to have new infections. So it's not just the prevalence of HIV and people living with HIV now for longer periods of time because of better access to treatment, but we continue to see large numbers of new infections, with estimated in 2019 of 1.7 million new cases of HIV just in that 1 year. So we're seeing the impact of kind of the convergence of these two pandemics, particularly in parts of the world that are experiencing high rates of HIV and HIV infections at this point, continue to do so at this point in time. Now, we've made great progress in the response to the HIV pandemic. And as I mentioned before, we don't have a vaccine. And it's not for lack of trying. There have been efforts for several decades to arrive at an efficacious vaccine without success, but the efforts continue. But I think what's really been the game changer for the global HIV pandemic has been the access to a life-saving antiretroviral therapy, ART, particularly in low and middle income countries. And at the time, early on, and even in 2003, for example, when ICAP was established, or we established ICAP, there was barely any access to treatment in many parts of the world, and particularly in low-income countries like in sub-Saharan Africa. And what we've experienced over the past 2 decades is this impressive increase and historic increase in access to treatment, which is a remarkable achievement. Nonetheless, we are lagging behind the treatment targets. So the UNAIDS had established for 2020 to reach 30 million, 26 million individuals living with HIV to access treatment. But you can see here that actually the target was not achieved in terms of treatment targets. So we did not achieve the treatment targets, and we have a long way to reach those targets. At the same time, we did not reach also in terms of the HIV epidemic, the prevention targets. So the target by the end of 2020 was to have less than 500,000 annual new HIV infections. And as I showed you before, it was 1.7 million by 2019. So we neither achieved the treatment targets nor the prevention targets for tackling the HIV pandemic. And the challenge is that, and I think now the UNAIDS has established new targets that are for 2025. There are ambitious targets, but nonetheless, they try to build on this success, but nonetheless recognize that we still have enormous gaps, particularly in some parts of the world, and also particularly among specific subpopulations. Often these are stigmatized populations, often these are criminalized populations because of certain behaviors like injection drug users or sex workers or men who have sex with men. They are often discriminated against and criminalized. And that, of course, leads them to fear accessing some of the services, whether they be treatment or prevention services. So let me talk about HIV and COVID-19. So I think one of the important questions that are always asked by people who are thinking about these two pandemics is, what's the risk of COVID-19 or SARS-CoV-2 amongst people living with HIV? And the data are limited, so that's important to highlight first. But it's thought that based on available data, and we need better data, that people living with HIV on effective treatment on antiretroviral therapy, effective ART, are at similar risk to COVID-19 when you contrast them to people without HIV. However, it's believed that and again, the data are limited and not very definitive, that the risk may be higher for individuals living with HIV who have underlying health conditions, other comorbidities, and we know the influence of comorbidities on COVID-19, as well as those with weakened immune systems, meaning largely with low CD4 cell counts who are not on suppressive and who are not achieving suppressed viral load. But nonetheless, again, it's important to continue to do research to really definitively answer this question. In terms of prevalence, it's thought that the prevalence in one study was of SARS-CoV-2 prevalence amongst people living with HIV is between about 0.6 to 1.8%, which is similar to the prevalence reported in the general population in this one study. Now, what about outcomes of COVID-19 amongst people living with HIV? And here we're beginning to accumulate more data, although they're not consistent, again, the data. But the evidence seems to suggest, at least the evidence from the better studies, the ones that have the larger numbers of participants, the ones that are have better methodologies, is that it appears that people living with HIV with COVID-19 experience poorer clinical outcomes, particularly those who are, as I mentioned, immune suppressed or not receiving antiretroviral therapy. So it's estimated that for people living with HIV, they represent about 1% of total COVID-19 hospitalized patients with COVID-19. And it's thought that in one study that amongst people living with HIV who had symptomatic COVID-19, that 66% had mild symptoms, of 22% severe symptoms, and 12% needed critical care. And in this one study from New York State that looked at COVID-19 diagnosis, hospitalizations, and in-hospital death, you can see here in the rate ratio, what was noticed was that there was an increased risk of hospitalizations, in-hospital death, as well as, of course, per population as well as per diagnosis. So this again suggests that people living with HIV are experiencing poorer outcomes when they have COVID-19. And this was similar findings were noted again in this blue color for people living with HIV, in the red for people without HIV. This is looking at cumulative mortality, early data, nonetheless, from this pandemic from last year, but they show again appear to be higher mortality amongst people living with HIV who also had COVID-19. And one of the important pieces of information and studies was the study that was done in Western Cape in South Africa. And this looked at all patients in Western Cape that access the public sector system there. This looked at 2.4 million patients who access the public sector services, and they had a total of about 22,000 people with COVID-19, including about almost 4,000 people living with HIV. And what was noticed is then they were looking at mortality, and what they noticed is that there was again the increased risk of mortality amongst people living with HIV. You can see this here, about twofold amongst people who are living with HIV versus those without HIV. And of course, the study showed, not surprisingly, some of the other risk factors for poorer outcomes, for example, certainly advanced age, older age groups, as well as people with comorbidities. And this has been noted before, as well as people with current tuberculosis. So now I'm going to switch from the effect of SARS-CoV-2 or COVID-19 on people living with HIV to more looking at the public health system, looking at the services themselves, and talk about the impact of COVID-19 on HIV services. So we know already that there are severe impacts that happen based on from outbreaks or epidemics on the health system. And at ICAP, we've noticed this over the years, and we were involved, for example, in the Ebola response in West Africa, and of course there are direct effects of the pathogen itself that's causing the pandemic, like the Ebola virus itself or COVID-19, but there are these indirect effects and what I call the spillover effects of something like COVID-19 or Ebola. And why does it happen? It happens because of decreased supply of health services, and I'll give you examples of this. Decreased demand for health services, so both the supply end as well as the demand end. And this leads to decreased coverage and quality of the health services. And of course, this is a cascade then that leads to worsening outcomes and in some situations, lack of trust in the health systems and weakening of the health systems and increase in morbidity and mortality. And examples of the impact on COVID-19 of the decreased supply is there's been, as you are well aware, for example, a cancellation of elective surgeries, which of course has happened here in this country and around the world. Resources, for example, the staff are diverted from their usual responsibilities to the emergency response in tackling COVID-19 or whatever the emergency is. Staff shortages due to illness, COVID-19, or due to quarantine, the need to quarantine because of contact. Interruptions of supply chains, and this has been noted, particularly with limitations of transportation and supply chains, whether it be for test kits or medications. And then, of course, the crowding, long waiting lines for as people become more sick, and shortages of equipment and supplies. And we know, of course, that we experience this even in our highly resourced country. What about the decrease in demand? And I think we've noticed that for years before in the Ebola epidemic in West Africa, is that people are afraid of infection. So this leads people to defer their visits to health facilities and also avoid healthcare workers overall. And of course, the other important impact on the actual protective measures, the preventive measures like lockdowns, travel restrictions, curfews that have been imposed in several countries. All of these lead to difficulty in traveling and prevent people from accessing health facilities. And lastly, economic hardship, which is, of course, very important and has been experienced all over the world, but obviously this has a disproportionate impact on the poor, and that makes it very difficult to be able to pay the transport that's needed to go to access the services and so on. And there have been a lot of reports of various manifestations of this decreased demand, as well as also the decreased supply, and that's been experienced in the context of COVID-19. And this is a prediction that actually was noted several years ago, now a year ago, not a year and a half ago, is that be an increase in tuberculosis-related death, there'll be a decrease in access to treatment, as well as increase in malaria mortality, and again with an increase in maternal maternal mortality and infant mortality, and of course a decrease in routine immunizations, access to drugs for non-communicable ongoing treatment, decreased access to reproductive health services, and of course the impact on poverty that I mentioned before. And in the context of HIV and particular, these are headlines, and these again showed that the disruption, the predictions at that point, these are early reports of the anticipated dire impact of COVID-19 in terms of disruption of services, access to medications for HIV, and also as well for tuberculosis. There have been surveys that have been ongoing to determine exactly the service delivery disruption. And this is a survey that's been repeatedly done by the Global Fund. And you can see for HIV programs, for example, since we're focusing on HIV this morning, is that 66% of countries reported such a disruption of HIV programs. And particularly here, you can see in the red, we don't see it in HIV, but if you look at the other colors, like let's look at the orange color, this means a high level of disruption. 10% of the countries are reporting this. In yellow, moderate disruption of services, and then in green, no or low disruption of services. And again, you will see this as well, the survey and the reporting from TB and HIV. Now let's look at, I wanted to touch a little bit of ICAP and our work, and then tell you about a study that we did. So just to mention, as was mentioned before, that ICAP is a global health center here situated at the Mailman School of Public Health, and we work around the world. But as you can see from this map is, as well as in the United States, with 2 research sites actually in New York City, one in Harlem and one in the Bronx. But as you can see again here in this map, that a lot of our work is focused on sub-Saharan Africa, also Central Asia, as well as in Myanmar, Southeast Asia, and now expanded work in Central and South America. And we focus on a lot of different areas of work, particularly our roots are in HIV. But over the years, of course, as you work around the world, you notice all the other problems, and have expanded our work to include areas like TB, malaria, maternal child health, and non-communicable diseases, and of course, most recently pivoting to respond to COVID, but as well a focus on strengthening the health systems overall. So we've always had this lens of looking at how can we impact strengthen the health system so that they can actually be able to respond to not just one specific health threat, but all of the health threats that are prominent in a specific context. So we did this analysis that I wanted to share with you to look at the impact of COVID-19 pandemic and HIV services. And we looked at these various critical HIV services that are along the pathway of the HIV testing and care cascade. Looking at the impact on HIV testing, on the use, initiation, and use of antiretroviral therapy, on viral load testing, as well as on viral load suppression. And these are, of course, are very important steps in the testing and care cascades. And we looked at this over several quarters. And we used as kind of the pre-COVID era, which is what we're calling Q1, which is Q1 of this past fiscal year, which would be in the fall of 2019 as the pre-COVID era. And then the Q2 is the first quarter of 2020, which is when the restrictions started. Restrictions continue, and then in Q4, which is when some of the countries have started relaxing some of the restrictions, and this would be Q4, would be kind of the more or less of the summer. It's like from July to October of 2020. And we looked at the data from more than 1,000 ICAP-supported health facilities in the countries you see here, in all of them. This is focused on sub-Saharan Africa. And on this map, you'll see the numbers of facilities in each of the countries where we examined for this analysis here in these various countries. And what we try to do is to divide these countries that you see here on this map in this analysis based on the stringency of medication measures. And there is an index, a composite measure of this. And it's based on 9 pandemic responses, whether you have school closure, workplace closure, cancellation of events, restrictions on public gatherings, closure of public transport, et cetera, et cetera. And we dichotomize these countries into more stringent ones with a higher score and less stringent ones with a lower median score. And then we examine the findings with regards to these critical services across the different quarters by these stringency measures. So what's interesting is when we looked at testing, which is really the foundation of any HIV program, and again, this is Q1 pre-COVID, and we're looking here at the number of individuals that received an HIV test at these supported health facilities that I mentioned, the more than 1,000 health facilities. You can see here that, again, this is the number tested. And what you notice is between Q2 and Q3, this is the time of course, the imposition of these restrictions, is there was a decrease by about 3.3% in the numbers of individuals that received an HIV test. But what was interesting is that was a rebound that was noted between Q3 and Q4 by increase by 10.6%. And the good news is that the yield, the positivity amongst those tested remained very similar, meaning that the people at risk did not change. So still the testing was getting to the people who needed to be identified. So there were, like here in Q4, 23,000, more than 23,000 people with positive tests were identified. Now, when we looked at the testing by stringency level, and you can see here, this is the countries, the health facilities in countries with high stringency measures versus with lower stringency measures. And you will see again here that there was this dip that was noted between Q2 and Q3, with some recovery in Q4, but you compare that to health facilities in countries with low stringency, there was an ongoing continuous increase in the numbers of people that were tested. If you look at antiretroviral therapy initiations, you'll see here that, not surprisingly, again, is because you're identifying fewer positives. There was a dip that was noticed between Q2 and Q3, almost 10%, but again, a rebound that was noted again from Q3 to Q4 as the pandemic continued. And then the actual total number of people living on HIV, and you can see here, this is currently on ART, starting out in Q1 with about more than 419,000 individuals at these supported sites that we support. There continued to be an increase overall throughout the pandemic over the past year. And then importantly, viral load testing and viral load suppression, because that's of great concern, obviously, because that's an important metric. And you'll see here in this figure, and this is the number of people who received the viral load test. And you will see that over the different quarters, there was an ongoing increase actually in those who had a viral load test, which is really, really reassuring. And then when we look at among those who had the viral load test, what about viral load suppression? And you will see here again, there was a slight increase from 87.5% to about 90%, or very similar. But anyway, there was no decrease noted in terms of viral load suppression, which is very reassuring. Now, why did this happen? And I think it happened, why did the HIV service, at least in the context of the facilities that we support and the countries in these countries, why did they demonstrate such resilience? And I think because there's been this movement towards what we call differentiated service delivery, or DSD for short. And these are less intensive treatment models. There's been a huge effort ongoing. And ICAP is leading such an effort with a network that we are leading that is focused on the scale up of DSD models, and that's funded by the Bill and Melinda Gates Foundation. And this has been focused on really developing a growing experience with these less intense models, whether they be facility-based or community-based. So for example, at group models to use facility-based clubs, or fast-tracking antiretroviral refills, or appointment spacing, like giving people a multi-month prescriptions of ART, for example. And then there are community-based models as well that include mobile outreach, include individuals who live in a certain community who come together and form a community ART group, and only one member of the community goes to the health facility to pick up the medications for everyone. So there's been already for the past several years a movement towards this idea of the differentiated service delivery models that, like I mentioned, I gave you some examples of these here, of these models. And you can see from the data from the same countries and the same facilities that I showed you before, this is multi-month dispensing of ART. And then this yellow color is scripting for less than 3 months supply, versus in this maroon color, 3 to 6 months, and then more than 6 months supply scripting of medications. And you'll see here there's already been a movement to go from frequent scripting to less frequently dispensing of medications. And you can see the increase that occurred between Q2 and Q3 with COVID-19. And we and others were really supporting countries to rapidly move so that the individuals could have access to the medications without the need to come to the health facilities. And I don't have time to show you, but there are lots of other models of care that were put in place to enable this to be done through going to deliver the medications themselves, and many other interventions that were made that are to facilitate access to treatment and services. But the UNAIDS 2020 World AIDS Report did say that, summarized that there were 84% of countries with sufficient data, they reported some disruption. So we saw an effect of COVID-19, but we saw a rebound that happened as COVID-19 actually was ongoing in these countries. And that UNAIDS overall reports that 75% of countries with sufficient data reported disruptions in initiation for those who tested positive, and widespread disruption in HIV prevention, and so on and so forth. So what we noticed is that there actually was that the programs really demonstrate remarkable resilience in a lot of ways that were really very, very impressive. Now, I'll quickly touch on what one pandemic can teach us in facing another. And these are just thoughts that we can discuss. I think for many of us, several of us on this call who are old enough to remember the beginning of the pandemic, there are really some profound similarities. One of them is the times of uncertainty and great fear, whether it be this is in the early 1980s, and this is, of course, with the COVID-19 pandemic. So this is kind of very reminiscent for those of us who experienced the advent of these two, is there are times enormous fear and anxiety, of course, when there's a new disease, a new pandemic that's coming along. The other thing is the importance of stigma, and clearly we recognize the stigma associated with HIV, but I think many of you will also note that we did note also a stigma associated with COVID-19 as well, and particularly who gets COVID-19 and the misperception that certain groups, for example, are the ones responsible for introduction of the virus in certain communities and also because the pandemic disproportionately affects certain groups. Again, the problem with discrimination and stigma against these populations. In addition, the problem, of course, always is the issue of myths and misconceptions. And that has been and is still plaguing the HIV response, and has also been, of course, the problem with issues around the COVID-19 itself, as well as the virus, as well as the vaccine. And one of those is always the issue of where did the virus come from? We've lived we've lived through this with HIV, and now we're living through it with COVID-19, as well as misconceptions about treatments. And of course, now we're seeing the myths about and the misconceptions about the coronavirus vaccine and its impact in terms of the uptake of the vaccine, which is so important. Then, of course, the disparities, and that is also seen. And this is just to show you in terms of HIV, just New York City, and the disparities in terms of HIV diagnosis and also in terms of positivity testing. And throughout this pandemic, there's been communities that have been most severely impacted than others, and lots of reasons for this that I don't have time to get into. But you know, often these pandemics really shine a light on disparities that exist in the society, as well as perceptions and misperceptions. And then, of course, the global disparities in terms of access to interventions. And this just shows you this is early 2002, and shows how the disparate access to treatment. And this is again here in high resource countries at that point in time, with access to ARVs in black here versus deaths from HIV, contrasting that with sub-Saharan Africa, where lots of people were dying with HIV and very few had access to treatment. And you know, this is always something that's in my mind, in our mind, as we now look at the map of COVID-19 access to vaccinations. And we saw similarly disparate access to testing and also to treatment, of course, of COVID-19, as we're seeing now in many parts of the world, including in India. And I think the other thing that I feel is a similarity, and an important one, is the importance of community-driven responses. And we've learned that from the HIV response, which has transformed really the approach to tackling health challenges. And we are now appreciating, of course, that we need to do the same for COVID-19, and ICAP and others are supporting this work of champions, health brigades, to get people who are engaged, who are affected or most affected, to be engaged in the response. And we've seen how that can make a difference in terms of, for example, COVID-19 vaccine uptake, and the importance of engaging the target populations themselves, and then champions from those populations. And of course, lastly, the importance of political leadership and will. This has been absolutely critical for the HIV response. We know what happens in the US with denial of HIV. We know what happened in South Africa with the president there when he's an AIDS denialist, and now South Africa has the largest number of people living with HIV and a severe pandemic. And we saw that as well with the lack of political will and how it can disrupt and hamper the response to a pandemic, a deadly pandemic. So I'll end with a few conclusions. As I'm sure you're aware, the COVID-19 pandemic continues to grow and evolve, and we're fortunate to have, at least in some high-resource countries, access to very effective and safe vaccines. But we are fortunate. I was just recently in sub-Saharan Africa and was in countries where people had very limited access, if no access to vaccines at all, and it's jarring to experience that same disparity that we experienced with early on in the HIV response, and that we're seeing that now with COVID vaccines. The effects of HIV, of COVID on HIV and HIV on the COVID outcomes continues to be defined. There are substantial COVID-19 spillovers on other health services and health outcomes that we need to think about. And evidence suggests, at least from the data, the large data set that I shared with you from our work, demonstrate a rather remarkable resilience of these programs in the face of COVID-19 pandemic. And lastly, there are lots of lessons learned from HIV. I sometimes say lessons learned, and then sometimes I use the term, it should really be lessons not learned from the HIV in terms of, and we sometimes keep repeating the same mistakes, unfortunately, in terms of all the things that we know are so critical to responding to a pandemic, which are importance of leadership, of effective and trusted communication, engaging communities, addressing stigma, discrimination, tackling myths and misconceptions very briskly and consistently, and of course, ensuring equitable access to resources. And thank you very much. And I'll end here and welcome your questions and stop sharing.
Hi, Dr. el-Sadr. Thank you very much for an amazing talk. We already have one question on the chat, and people are free, to keep asking questions, but we'll start with the one on the chat. It's from Dr. Seward. He's saying, what are the key lessons regarding inadequate access to testing and vaccines? As well, I assume, of treatment. Is the model fundamentally wrong? And can you comment on the 2 or 3 key ingredients to be remarkable resilience you described? It seems a lot had to do with the model of care, the brigades, for instance. How about the role of telehealth or telehealth?
Yes, yes, thank you very much. 2 very important questions. I think the problem with access to testing or access to PPEs, access to PPEs, is profound, and that's something that we did as well, is procurement of test kits and procurement of masks and ventilators and so on, as well as now vaccines, is that there is a fundamental flaw in the way we think of global health, particularly when it comes to, I think there's this disconnect of the sense that if we just take care of ourselves, that's going to be the end of the problem, rather than thinking of the interconnectedness of all of us, particularly when it comes to an infectious disease like COVID-19 or HIV and so on. And the problem is that there is really, I think, a fundamental challenge in terms of what we call global health governance, is that there isn't a strong consensus on a framework or an approach that is equitable, and that also takes into account the various resources available or not available, and how we can safeguard against hoarding. We know that there's countries that have been did hoarding are hoarding some vaccines. We also know that there was outbidding each other in terms of purchasing of supplies. So I think it's a fundamental flaw, I agree, in terms of the lack of a global health governance structure that everybody respects and buys into. And there's always been the hope, and I don't blame the WHO for this, because of course WHO is dependent on the buy-in from member countries, but the desperate need for having such a body or a governance that everybody respects and adheres to, and that is lacking at this point in time. And then the other is the resilience. I think the resilience, I can tell you that I was incredibly impressed. Like, for example, with the just when COVID struck, we have this network, a learning network that we established with many countries in sub-Saharan Africa, our member countries. And this means that actually the Ministry of Health is the member of this network. And what happened is that these individuals came together and we had these many calls and webinars and so on, how to share information and sharing of information, what works, what doesn't work, was one very fundamental asset, is that they were able to share lessons learned. They were able to tell each other, you can move to 6-month dispensing, you can do this, you can do that, it works. This and having the voices of the people recipients of care themselves, as well as the ministry. Then the ability to make decisions fast. And I'm always kind of struck by people have this, they always think that, ministries of health are slow, the bureaucracy is terrible. What I saw was remarkable. I mean, these leaders were able to say, as of tomorrow, we're going to do this. And they did it. And they recognized the emergency. They also recognized that they did not want to lose the gains that they had achieved. And they were able to make these decisions that, honestly, it would have taken us here months to come to a consensus. So I think those are some of the assets that I think helped to achieve this resilience.
We have another question by Dr. Braun, one of our pulmonologists. She asks, does social media not available in the AIDS era contribute to myths, and might it be recruited to counter that? How much is there a public and private partnership in addressing the disparities, and does it work?
Thank you. I think it's kind of interesting to think about the role of social media, and I'm certainly would agree that social media can magnify and amplify certain voices and certain myths. But for, like I said, the older individuals on this call, they will recall some very similar myths as well with HIV. So I remember people saying that the virus was really created at the NIH and Tony Fauci's lab, or that this treatment is poison, or I think people find a way to arrive at myths and disseminated myths, and of course, social media can amplify that, but it doesn't mean that these myths did not exist before. But I do agree that we need to then be able to, to mitigate this and use the same media more effectively than we have. And there are several watchdog groups that watch, and I'm aware of several that do sort of scan and keep an eye on some of the myths that are being promulgated on some of the social media, and they immediately will then respond to them. So one of their strategies is that the rapid response and sort of like verify and rapidly respond. And I think that I've seen them doing this. I don't know how effective it is. I think it will be interesting to see how effective. I'm not aware of, at least of studies that have looked at this rigorously, but there are groups that are now doing exactly this, of monitoring and then responding. They monitor Facebook and other platforms and then respond very briskly.
Yeah, thank you very much. I have another question. Actually, this is from me. We've had a very unusual flu season this year, when social distancing policies really gave us a very low number of new flu cases or influenza cases this year. Do you think it will have a similar effect on new cases of HIV? Do you think social distancing policies have also an effect on infections that are not, respiratory, that do not, disseminate through air? And do you have any data on that, or your thoughts if you think that might translate to less cases or no?
It's an intriguing question, something we've thought about. I think it's too early to say. That's my answer, because I think while it is true that the physical distancing, and obviously people there needs to be intimate contact to transmit HIV, that may decrease the risk of acquiring HIV infection in terms of numbers of new cases. At the same time, also, there's the fear that there's less. We don't have good data on access. We have some data on access to PrEP, for example, preventive measures like PrEP or access to condoms and so on because of either supply issues or demand issues. So we don't know how it's going to balance in the end, whether that's going to be manifest itself in no change in new numbers of cases or a decrease or an increase in numbers of cases. So, but we have looked at, we've done some work in surveys in one of our studies that we're doing in Kenya, that's PrEP related study, which had to move to a virtual mode. That, of course, for sex workers, this is a study amongst young sex workers. Obviously, they have less access to sex work venues and so on. So, so it'll be interesting to see how, like I said, access to prevention tools versus decrease in opportunities for risky sex, how that balances in the end.
Any other questions? We don't have any more questions in the chat, but feel free to unmute and pose your questions.
There's been a reduction in the expected birth rate.
Yes.
Over the COVID pandemic. So it suggests that social distancing, even in intimate households, is leading to less engagement. So the human behavior is driven by fear, and fear is a very profound, unfortunately, myth maker as well as that. So it suggests, and I'm really gratified that the influenza cases have been so little, but there's very little co-infection. And that's what's interesting to me, because they're both respiratory-borne viruses. And yet with the prevalence of influenza, did it meet a competitor that did not allow it to spread? So that to me is very curious. And I wonder if you had any thoughts on that.
I think, again, it's too early to say. I think what we need to look at are the data from, and the data from influenza seem to be quite convincing, actually, because there are influenza surveillance systems, and it's unclear, again, is whether, for example, SARS-CoV-2 is more infectious, which is possible, than influenza, and also certainly more deadly, and that may have also gotten, had people go for testing more frequently, and more symptomatic, more testing, more hospitalization, so more ascertainment as well. But as you know, there are also anecdotes of people who tell me all the time, I've had a great year, I didn't have any colds all year. Right. And that tells us that, of course, there's more hand washing, and which is very important for prevention and transmission of such viruses. So I think we're going to learn an awful lot as we look back and see across influenza, cold viruses, and as well as HIV transmission and so on, and the impact on. And I feel like there could be this idea, what we did in our study, which is looking at by mitigation, by the strict medication indexes, what's the impact on how strict the restrictions are, and how that influences also whether it's the risk for infection or spread of infection as well.
Striking reduction in infant mortality from both influenza and RSV. Right. That's really gratifying to me.
I think that's the silver lining, right? There are, and that's going to be part of I think of the history of this pandemic. I mean, there are several silver linings that, of course, there are all the losses, which are horrible, but all of these other things that we've noticed, and how do we harness some of what we've learned that, and exactly. sustain those gains? Yeah.
Yes, Wafaa, hi.
Yes, hi.
Yeah, it's George here. I've been thinking about the mortality, at least, in the early wave, it appeared that there was a much higher mortality than in this, I'm talking about here in New York.
Yeah.
In this recent wave in New York. And, how is the mortality based on the virus getting more vulnerable people early, or is it, because I can't believe it's the skill, as much the improved skill of the healthcare workers and the screening. And so I because skill is increasing
Mhm.
and more vulnerable people are being infected. So is there any thinking about that idea, or is it even an idea?
Yeah, no, I think you bring up an important point, and I think it's important to keep in mind that the mortality, the early data, the data from last March and April and May, for example, it should be taken with a grain of salt, because
Yeah.
we had almost no diagnostic testing. Remember, I mean, people would
Right.
come to an emergency room and they'd be told you're not sick and just go home, right?
Yeah.
So nobody, I
Yeah.
mean, so when we look at mortality rate in that period, the denominator is completely flawed because we have no idea how many cases there were.
Yeah.
So that figure that shows like the peak is now higher this peak than it was last year, I would dismiss that completely.
Yeah.
And because we had almost no ability to diagnose, so that's important to keep in mind. So while people say that the mortality is lower now, we don't know the denominator then to be able to say to compare now to before. So that's important to
Yeah.
keep in mind. The other thing is that, sadly, of course, is that we had the terrible epidemic in congregate settings like nursing homes
Mhm.
and other congregate settings. And that, as you're well aware, I think now is estimated like 40% of the deaths occurred in nursing homes. It's amazing.
Yeah.
So we have sadly depleted
Mhm.
in that wave a lot of the people most at risk
Yeah.
dying
That's
because of age and comorbidities and so on. So that's an important thing to keep in mind. And then, of course, older individuals or vulnerable individuals, either we depleted the population sadly, or they protected themselves better, after getting to know more about the risk of COVID. And then better knowledge of management. I think we clearly have learned over the months how to manage cases better. So I think it's a combination of some of it is real, and some of it is artifactual because of the populations most severely impacted and the data we have.
yeah. And
Professor
has
el-Sadr, thank
Yeah.
you very much. I'm sorry, George. Do you want to go ahead?
no,
Go ahead.
no. It could go on forever.
Well, thank you so much for all of your wonderful work. I really express that on behalf of the entire department, and also for sharing really wonderful insights and wonderful data related to COVID-19, as well as you described so well, the resilience in the programs you've fostered throughout the globe. So thank you again.
Thank you, and it's my pleasure. And thank you all, and have a good day. And all the best.
Wafaa, it's wonderful. Thank you so
Thank you.
much.
Take good care.